So welcome back everyone, as promised last time. So this week we'll be discussing multicolor imaging, and the question I'm trying to answer is it just a funny looking fundus photo or more? Before I go any further, again this important disclosure, this is not a sponsored video, and I have not been paid either by Heidelberg or any other company for promoting multicolor imaging, or I have not, there's no financial conflict to share vis-a-vis this presentation. So what is multicolor imaging? So last year in 2024 January, our institute installed the Heidelberg HRA OCT machine. The primary reason we purchased this machine were these two diagnostic tests. One was OCT angiography, and the other was the ultra wide field and fluorescein angiography facility. So these were the two things that we were, which actually we were looking forward to introducing in our clinic when we purchased the machine. However, we were informed that this machine also comes with this special diagnostic tool called multicolor imaging, which we thought was nothing but a fancy name for color fundus photo. And therefore, initially when we got the machine, we started using the multicolor imaging like a color fundus photo. For example, here is a patient of CSC. So on the left hand side, you can see the color fundus photo of the patient with the central serous chorioretinopathy. And you can see the multicolor 55-degree multicolor image of the same patient on the right hand side of the image. Now, obviously, this is how we usually think CSR looks, but this is definitely not how CSR appears clinically. And you can see this clear demarcation, something greenish. It was very odd. But this was not the only time when we were surprised. Here is another example. Now, this was a patient with grade 4 hypertensive retinopathy. You can see the edematous disc with superficial flame-shaped hemorrhages, left more than right. Now, these are the two color fundus photos. Now, these are the multicolor images of the same patient. And if you see, look at the disc is all greenish, and it's very different. It doesn't at all look like how we were expecting the image should come, because we were thinking this is just a color fundus photo. Even for a normal fundus, like in this case, you can see if we look at the normal fundus with a multicolor image, even here the disc looks black, which we know is definitely not the true color of a disc. In other words, it was very obvious to us that our approach towards multicolor imaging was wrong. This is not a color fundus photo. So why were we going wrong? So we realized we needed to dig deeper, understand the technology before we could apply it the right way in our clinics. So what is a color fundus photo? A color fundus photo basically is a flashlight photograph of the retina. So it's a fundus camera which uses a fundus camera which throws a single bright white flash light to capture a 35 to 50 degree true color image of the retina. However, multicolor image is totally different. This particular diagnostic tool comes exclusively with Heidelberg Spectralis machine, and here three different lasers, the green, the blue, green and infrared lasers, are used to scan the entire retina line by line, and individually these three lasers scan up to a different level of the retina, and then these three different reflectance images caused by the reflection of the lasers are combined by the computer inside the spectralis to create a pseudo color image, which we call the multicolor image. So it is a confocal scanning laser ophthalmoscopy based system using three different lasers, each penetrating to a different level into the retina. And then combining these three, the reflectance images created by these three different lasers to create the pseudo color multicolor image. For example, the three lasers, let's see here, this is a blue laser. So this is the laser that gets reflected primarily from the retinal surface. The green laser, again 515 nanometer, this actually gets reflected from the inner to up to the middle retina, and the infrared laser, which penetrates the deepest and covers the outer retina and the choroidal layers. After we have got these three reflectance maps, the machine combines these three maps to create this pseudo color image, which we also call multicolor image. In other words, this is not a single flashlight photo of the retina. Because it's a confocal scanning laser ophthalmoscope image of the retina, and because it's pseudo color, so it is totally different from a white flash based true color like a color fundus photo. In other words, as I said, multicolor image is not color fundus photo. Actually, in reality, it is superior to color fundus photo. And I can vouch for that after having now used this diagnostic tool for nearly 2 years in my clinic. So let's see what are the benefits or the edge that multicolor image provides us vis-a-vis color fundus photo. The first thing is the color fundus photo is a flashlight based system, whereas this is a scanning laser ophthalmoscope. So naturally the images are in high contrast, which means you can pick up fine details. These two images are of the same patient. On the left hand side, you can see the color fundus photo, where you can make out these retinal striae, which suggest, the straightened retinal vessels, which suggest that there must be an epiretinal membrane there, but you can hardly make out the membrane. But look at the multicolor image. You can make out the entire edges of all the entire extent of the multicolor of the epiretinal membrane with all the edges sharply defined. And you can also see the effect that the epiretinal membrane is having on the retinal surface. Second, this is another place where the multicolor image I have found to be highly useful because of the high contrast. And this is a situation where you have proliferative diabetic retinopathy. Look at the color fundus photo. So you can make out there is a new vessel here, probably fibrotic new vessel here, and there is a pre-retinal hemorrhage here. But nothing, you can't really comment on the extent of the new vessel just by looking at the color fundus photo. But if you look at the multicolor image, look at these sclerosed vessels. So just by looking at this, you can make out the severe degree of ischemia in this patient. Then you can make out each and every new vessel, this large NVD front, part of which is fibrosed, part of it which is still highly vascular. You can make all these NVE fronts, and you can even make out the effect these NVEs, these fibrotic NVEs are having on the retinal surface. You can make out this clear surface, this traction on the surface, which obviously you can't make out on this color fundus photo montage. The second advantage that a multicolor image has over color fundus photo is that because it's a laser based imaging system, it is unaffected by the media. Again, here are the color fundus photo and the multicolor image from the same patient. Now this patient had a cataract, and this is another great use of multicolor imaging system. If you have patients of cataract who have been sent to you for retina evaluation prior to planned cataract surgery, often it's very difficult to make out, even with fundoscopy, especially in presence of a hazy dense cataract, fine abnormalities on the retinal surface. Like for example, if we see this color fundus photo also, we can see the half of it is not clear because of the media opacity. Whatever little is seen, it appears normal. You really can't comment much. Look at the multicolor image. Everything is clearly seen. The media opacity is not degrading the image nasally, And look at the epiretinal membrane, which stands out prominently, and you can even make out that this epiretinal membrane is circumferential to the fovea, which also tells you what effect this epiretinal membrane may have on the post-op vision. In other words, if you have a multicolor imaging facility, evaluating patients in the pre-op stage, prior to a cataract surgery, evaluating the retina becomes really easy, because the multicolor image is not degraded by media opacity, as it is a laser ophthalmoscopy, scanning laser ophthalmoscope based system. Here was another case. This again patient had a dense cataract in his grade 2 plus. The color fundus photo appeared normal, but if you can see here, the multicolor image clearly picked up a resolving macular BRVO and cystic changes, which were confirmed on the OCT. As a matter of fact, not only is the multicolored image providing higher contrast, which helps us find each and every pathology in higher details, and not only is it not affected by media opacity, actually a multicolored image contains much more data than any color fundus photo, because the color fundus photo is a flash photograph, which is practically a two-dimensional image, which is based on the reflectance of the white light from the retinal surface. But here you have basically three different maps of the retina from three different planes, which are being combined to create a composite image. And therefore, if you look carefully at not only the multicolored image, but the corresponding blue, green and infrared reflectance maps or images, you can make out much more about the pathology and the level at which that pathology lies and the effect it is having on the retina than a color fundus photo can ever tell you. So let us see a few examples to understand this better. For example, here is a patient. Now this multicolor image is of a patient with a epiretinal membrane. Now if we look at the blue reflectance map, which is primarily reflection from the surface, as expected, the ERM is most prominently seen. For example, compare this with the infrared reflectance image, which is from the outer retina. You cannot really make out the epiretinal membrane, right? So a surface pathology like the epiretinal membrane will be seen much more clearly on the blue reflectance map than an infrared reflectance map. But if you look at the infrared reflectance map in this particular case, you can see the retinal distortion. So what does that tell us? It tells us that this ERM is not only distorting the retina, actually it is distorting it quite strongly enough to have the impact of that distortion reach up to the outer layers of the retina. So one, if you have a surface pathology, you will find it more prominently on the blue reflectance image. Two, if you want to see what is the impact of that surface pathology on the outer layers, you can then look at the other two reflectance map, especially the infrared reflectance map, and easily estimate that. Now the green reflectance, as we have already said, is from the inner retina up to the middle retina, say, and therefore is very useful to study retinal vascular pathologies, because we know the retinal blood vessels supply up to the top half of the retina, and this is where the green reflectance map, green laser gets reflected back mostly from. So for example, in a patient with a diabetic retinopathy, if we compare the green reflectance map with the green reflectance image with the blue reflectance and infrared reflectance image, at every stage we'll see that the green reflectance image tells us more about the pathologies in the inner retina than the blue or the infrared reflectance image. First, look at this NVE. Now if you see this NVE, it is so clearly seen in the green reflectance image. It is barely seen in the infrared reflectance image, because obviously we know NVEs lie on the surface. They lie on the surface. They are not lying in the outer retina. In the blue reflectance image also, as expected, the infrared, the new NVE is seen. Next, look at these retinal hemorrhages. So we know again these flame-shaped hemorrhages are in the, flame shaped and dot hemorrhages. These are part of the inner retina. So again here you can see the blue reflectance image is showing those hemorrhages, but not adequate, not as many as the hemorrhages are there. If you look at the infrared reflectance image, you can hardly see the hemorrhages, as if they are not existing. And the green, of course, you can see the exact amount of the hemorrhages as is there in this particular patient. Next, let us look at the hard exudates. Again, you can see it is best seen with the green image, a green reflectance image, hardly made out in the infrared, because it is not reaching up to the outer, it is not something located in the outer retina, and also barely seen in the blue reflectance image. In other words, each of these pathology in diabetic retinopathy, depending on at which level they are, will show up more prominently in different maps. And in general, the common signs of diabetic retinopathy, because they are inner retinal signs, or they are mostly located in the inner retinal area, they will be seen best in the green reflectance image. Next, if you have an outer retinal pathology, for example, this case of RP degeneration secondary to post, in a case of resolved CSCR, you can see that best in the infrared reflectance image. Now, if you compare, for example, this infrared reflectance image to the blue reflectance image, where you can immediately make out this is from the surface. So you almost see no lesion here, as if the retina is absolutely normal. It's only from the green reflectance image that you can start making out there is some pathology, but it is the infrared reflectance image, which is from the outer retina, RP, at that level, that you can clearly make out the extent of the RP atrophy and the severity of the RP atrophy. So because multicolor imaging helps us define the depth of the pathology better, this can be very useful in the clinics. For example, here is one patient who had a pre-retinal hemorrhage. Now, if we look at the blue reflectance map, you can see that this image is this blood is sub-ILM, and you can see the ILM, internal limiting membrane, stand out clearly in front of the pre-retinal hemorrhage. So this is a sub-ILM prefoveal bleed. In the green reflectance image, again both the ILM as well as the blood is seen very clearly. But if we look at the infrared image, here the ILM is that that was so prominently highlighted in the blue as well as the green, it is almost not seen, and only a little amount of the blood is seen, which is probably lying at the trough of the foveal concavity. Now, if we compare this with the OCT, so we can clearly see, yes, this blood is prefoveal sub-ILM. So just by comparing the three images along with the multicolor image, we could easily make out the level of the pathology. Now, if you have a deep lesion, for example, in this case, we can see some elevation is there with some RP changes. Something green means that either retina is elevated or detached. Now here, if we look at the blue reflectance, again you see it looks absolutely almost normal. So we know this is not a surface elevation, it is something deeper. In the green, you can now start to make out that there is something, but not really much. And of course, these RP atrophy areas, these are not at all seen either in the blue or the green reflectance map. However, when we look at the infrared map, we can now see the pathology along with those RP atrophy patches. So we know this is an outer retinal thing which is pushing up the retina. And the OCT gives away the diagnosis of a choroidal hemangioma, which was elevating the retina. So with all these benefits of higher contrast, not getting degraded by media opacity, and also with those four maps together telling us where the lesion lies and what effect the pathology is having to the different levels of the retina, we can actually claim that multicolor imaging is not just a photograph of the retina. unlike a color fundus photo. It is actually a diagnostic tool which is with its own unique uses in the clinics. For example, in CSCR, here are three images of patients of CSCR. In acute CSCR, when there is only the serous detachment and no RPE changes, you can expect a greenish elevation like this. Now, when there is a retinal elevation, it looks green in multicolor image, primarily because like for example, in serous detachment, the infrared laser is dampened and the green laser is easily reflected back by the inner retina. So that's why it looks more greenish. So similarly, if the retina is elevated also, it will look greenish. Now here also you can see it is this area where the retinal detachment is there, it is standing out clearly, it is demarcated and it is appearing greenish, but by comparing these two images, we can make out that the greenish tinge is much less in the middle compared to the image on the extreme left. Now this is because this is a case of a persistent CSC, and we know in persistent CSC with time the serous detachment sort of reduces, and in its place rather we expect RPE changes to come up. So you see these red dots. Also, if you look carefully, you can make out these yellow small white dots which correspond to these subretinal precipitates, which are all signs of now this CSC, which was an acute case, converting slowly to a persistent CSC or showing signs of chronicity. And therefore we know that this CSC, which is in acute stage with no evidence of any RPE changes, can be observed, but this we need to probably intervene. This is obviously a patient where the CSC has resolved, but it has left behind a large patch of RPE atrophy, which can also be confirmed on the OCT. You can make out this clearly that the fovea is thinned out. In patients of vein occlusion or diabetic macular edema, that means any patient where there is a macular edema, again multicolor imaging can be of great use. For example, this is one patient of a superotemporal BRVO who presented to us a bit late. You can make out this clearly by the OCT and also by the multicolor image. You can see these gross cystic changes. You can see the sclerosed vessel here. You can look at this greenish patch which tells us that this area retina is thickened. That means there is edema. It also tells us how wide is the area of, or how large is the area of edema. By making, by just looking at this area, you can make out this is our entire area is edematous. And you can see this OCT gross cystic changes. There is also loss of these central columns, which tells us that this is a really chronic case and visual recovery may be little less than we would have desired. So anyway, this patient was treated by an intravitreal Ozurdex implant, a Dex implant. Now you can see this edema has gone down significantly just by looking at the multicolor image, because you can see this greenish tinge has now disappeared. So we know that the edema is not there and the OCT confirms the same. However, 4 months later, the patient's vision dropped, and just by looking at the multicolor image, you can now make out that not only has the edema come back, it has probably worsened than in the baseline. And you can see these multiple cystic changes here, along with this larger area of greenish discoloration. That means there is a larger area of edema. And on the OCT, we can see the same. There is intraretinal fluid, subretinal fluid. So at this stage, we repeat the Dex implant. Again, after 2 months from the second injection, that means nearly 6 months from the baseline, you can see the edema has now resolved once again, because you can see no greenish discoloration here. So just by looking at the multicolor image, we can make out whether edema is there or not there, and if edema is there, what is the area, how much is the area that is edematous. Now how is this useful? This is most useful for us to counsel patients. Besides, of course, it becomes an easy diagnostic tool for us to also make out whether edema is there or not. It really helps us to tell the patient that, see, this is the area where the retina is not healthy, and you can then see after injection how this area is recovering, and so on and so on and so forth. So I have told you how multicolor imaging really helps you pick up or differentiate acute CSC from patients who are going into chronicity. I've also told you how it can be very useful in monitoring patients of macular edema. Next comes proliferative diabetic retinopathy. So I've already told you that in DME, where you are monitoring macular edema, multicolor imaging is very useful. I have personally found it to be extremely useful in proliferative diabetic retinopathy. So why is that? So in proliferative diabetic retinopathy, we know it is the main highlight is the presence of new vessels, neovascularization. Now in multicolor imaging, you can very easily make out whether the new vessels, first of all, it will help you diagnose each and every new vessel because it is a high contrast image. Second, it will also tell you whether the new vessels are fibrous, as in this right hand image, or they are highly vascularized. Because we know if you have a highly vascularized new vessel like this can bleed anytime. If you have, however, a fibrous new vessel like this, probably it has stabilized. So this is obviously very useful. And this is also useful when we are monitoring a new vessel. So if we are treating a new vessel, if it was at the beginning vascular like this, we would want it to become fibrous like this. For example, in this patient, there was a large NVD with NVs and pre-retinal hemorrhage. So it was a unstable PDR, and we gave an injection of an anti-VEGF. And this is after 2 weeks. You can see how beautifully the new vessels have regressed, as well as the resolution of the pre-retinal hemorrhage post that single anti-VEGF injection. So this is not something that we are not aware of. We know that anti-VEGFs have very good effect on the regression of new vessels, but to actually get to see that, that such a large NVD front which has now beautifully regressed, that is really helpful, because now by just monitoring this regressed front, you can make out when it starts reactivating again. In surgical retinal cases, also multicolor imaging can be very useful. For example, in epiretinal membrane, multicolor imaging has been found to be a wonderful tool. Not only it helps us pick up epiretinal membranes like this, you can see clearly the membrane, it stands out so prominently. You can see the entire extent of the membrane. Also, you can see this surface wrinkling. So not only can you see the entire membrane, you can also easily make out by just looking at the multicolor image whether the epiretinal membrane is impacting the fovea or not. For example, in the patient on the left hand side, you can clearly see that the fovea is disturbed by the contractions or the effect of the epiretinal membrane on the retina. But for the patient on the right hand side, you can see the epiretinal membrane is circumferential. It is surrounding the fovea but not actually affecting the foveal pit. Again, something that is confirmed by the OCT. But if you had not even looked at the OCT, just by looking at these multicolor images, you could have made out the same. Another useful indication or clinical application of multicolor imaging is in macular hole. So for example, we have two cases of macular hole. Both are looking pretty large. Now if you ask me that which one do I think is likely to gain back vision if we operate on both the cases, is a right hand side patient more likely to gain vision, or the left hand side patient? Now of course we know by looking at the OCT we can answer that question, and I have shared that in a previous video on macular holes. But say if you do not even look at the OCT, if you just look at the multicolor image, even then you can easily make out which of these two macular holes is likely to do better. That means likely to gain more vision post-op. So on the macular hole on the left, you can see there is a greenish hue all along the rim, neuroretinal rim, all along the rim of the macular hole. Now we have already discussed that anything, if the retina appears green, it means it is elevated, it is edematous, or it is getting lifted or something. So here you can see this cystic changes in the macular hole, edges of the macular hole on this eye. And we know presence of such intraretinal cystic changes suggests that this hole is, even though it's large in size, it is not very chronic, and therefore not only likely to close with a single surgery, but also there is a hope of some visual recovery. If you look, however, on the macular hole, at the multicolor image of the macular hole on the right hand side, you will see there is no greenish hue. So this absence of greenish hue tells you that these edges are not cystic, which is confirmed again on OCT. These are atrophic edges, and you can look at rather that there is this reddish tinge. Instead of the greenish tinge, you are having this reddish tinge, which further confirms the presence of atrophy and RPE loss, which tells you that even if you somehow close this hole, which may not close easily, but even if you successfully do that, still the chances of vision recovering in this particular case is less than compared to the one on the left. But though I have now shared with you a lot of positives of multicolor imaging, like every good thing in life, it also comes with some limitations. For example, some findings may be missed on multicolor imaging. One such finding is presence of fibrin. So if you have a CSC with subretinal fibrin, like these two pictures of the same patient, you can see the fibrin was clearly seen on the color fundus photo as well as on the OCT, but it went completely missing on the multicolor image. This may be because of the infrared laser easily overcoming the fibrin. So therefore, unlike the white flashlight which probably got reflected from the fibrin, here the infrared laser went through and through, and therefore the machine could pick up there was some elevation which is represented by this greenish tinge here, but nothing else. And besides missing some findings like the one which I have just shared, sometimes multicolor imaging is not enough. And this is again something that we must remember every time, that there is no single test which can diagnose everything in every patient. So it has to be a combination of tests. That means multimodal imaging is always better than a single imaging technique. For example, this patient. You see this patient of a diabetic retinopathy, you can make out that there is a venous loop, there are some hard exudates, cotinal spots, probably severe NPDR, and you do an OCT. So the OCT shows there is some cystic changes, center involving DME, but the OCT angiography also shows yes, there is not much change in the superficial vascular complex, but the deep vascular complex shows some dropout of capillaries, nothing significant, so not much of macular ischemia. So if you are just going to depend on the multicolor image and OCT at this patient, if the visual acuity is worse than 20/32, that means 6/9 or worse, then probably you will say, okay, this is a center involving DME, patient needs treatment for DME. But in the same patient, once we do an angiography, the wide field angiography, which corresponds to the 55-degree multicolor, corresponds to the 55-degree multicolor image, that means both are covering the same area. So in that we don't see any pathology at all, or rather I should say any pathology at all to change our plan of action. So we see yes, there are some capillary non-perfusion areas, there is a venous loop here, but we would still say, okay, this is a severe NPDR with center involving DME. However, once we go to the ultra wide field angiography, the whole staging of the DR changes with all this vision threatening NVEs, severe capillary dropouts. So now you know this is not just a patient of a center involving DME with severe NPDR, it's a patient of a proliferative diabetic retinopathy with center involving DME. Now you may wonder how common is such a scenario where the pathology of the diabetic retinopathy is primarily in the periphery and we would have missed it without doing an ultra wide field angiography. Well, it is not uncommon. It is seen in 10 to 14% of the cases as reported by DRCR protocol AA, and we can discuss that protocol sometime in the future. In other words, in this particular patient of diabetic macular edema, once again we see that if we had depended just on multicolor imaging and OCT, or even did done a OCT angiography, still we would have not been able to grade the diabetic retinopathy appropriately without this wide angle and ultra wide field angiography. So you can see these areas, these are the asterisks, the stars and these arrows obviously highlight the pathologies which I have already discussed. So the question that we started, is multicolor imaging just a funny looking fundus photo? Because people who have never seen a multicolor image initially struggle to adjust to it. Because when you look at a CSR, you do not expect a greenish round image instead of the normal, serous detachment as it appears in fundus. But now after I have explained to you like why a multicolor image appears the way it is and what are the advantages, the great advantages it has over color fundus photo, I'm sure you will agree that a multicolor image is not to be confused with a color fundus photo. The two are totally different. And therefore, the answer to this question is a loud resounding no. So before I end, I would just say that if you should appear, if you are really wondering how do I approach a multicolor imaging, or whether I should even go through all the pain of understanding a multicolor imaging. So I'll just share one situation. So for example, look at this photo. So imagine you are standing in the middle of a forest, as somewhere, like I'm from Siliguri, and close to Siliguri there are a lot of dense forest. So say you in the middle of the night go and stand in the middle of the forest. With your naked eye, you will probably see nothing. It will be all dark like we are seeing here right now. But if you have an infrared goggles or a camera, and if you put that on, then probably you will start seeing so many wildlife around you. Now these wild boars here, which we are seeing because of their body heat, which are showing up so beautifully in the infrared camera. Now they obviously are not red or pink in color, so they are being shown in pseudo color. So this is not the true color of a pig. But just imagine, without this technology of the infrared camera that you are using now, you would have not seen the pigs at all. In other words, we do see things in pseudo color in multicolor imaging, but we get to see much more than we can ever see with a true color fundus photo alone. So thank you so much. I hope I could explain how multicolor imaging has really helped in my clinical practice. And if you have access to multicolor imaging, nothing like it, it's really wonderful. And in case you do not have access, maybe you can consider getting it in your clinic. So this was the lecture for this week. Next week, I'll be coming back with an interesting case. And till then, do let me know how you are liking our classes or videos through the comment section. If you feel that our videos are really interesting, do like them and share them with your friends, because our whole approach is that if we can, I wish to actually reach out to more people who would want to get information about retinal diseases, retinal diagnostics, and other retina related pathologies, other retina related topics. And the more you like and share these videos, it encourages me and also probably will help tell YouTube to promote these videos so that we can reach out to more people who may be interested in these topics but might not be aware of the videos that I am sharing. So thank you so much. Thank you for your patient hearing. See you soon. Thank you.